Hi folks, I'm Evan Taylor. I'm here to talk to you today about the Cancer's Margins project. So Cancer's Margins is the first, as we said, first nationally funded project in Canada that looks at the intersections of gender marginality, sexual marginality with cancer health and decision making. We're funded by the Canadian Institutes of Health Research and of course the PSI, thank you very much. We are in a partnership. There's 5 different universities across Canada that are partnering with this. We have researchers at all those universities, and we're now moving into the knowledge translation portion of our work. So what we're doing is we're talking about our results, and we're doing this through traditional academic avenues such as journal articles and manuscripts, but we've also released a website recently, lgbtcancer.ca, and this is the very first online archive of queer and trans people's experiences and stories of cancer. Of course, research is very important when it can inform how it is that healthcare is designed, so that's a primary purpose of this project. But also to start to investigate how it is that LGBT health research is done. When we start looking at some of the health disparities, we're looking at health disparities in terms of cancer for LGBT people, but when we're looking at LGBT cancer, we're talking about both gender and sexuality, and we're conflating them. So one of the important things about this project is that we're starting to really delineate exactly what are the differences between gender marginality and sexual marginality in terms of people's experiences of cancer care, which is very important. If we're going to start addressing some of those health disparities, we have to importantly connect medical competency with cultural competency. It does us absolutely no good if we know exactly how to treat people culturally, but we have no medical competency, and it does us absolutely no good if we have all the medical competency in the world, but we can't get people in the door to get treatment. So the research methods. We have to this point interviewed over 120 participants and members of their support networks. This particular piece I'm going to talk about today for the next couple of minutes is just the subsection of 10 trans and gender nonconforming folks who are diagnosed with breast and gynecologic cancer. And the study itself is designed around the social study of medicine. In terms of demographics, I'm not going to get into the individual details of every single person, but suffice to say, we have an age range of about 35 years, between 30 and 65, race and ethnicity mapped onto that of the general Canadian population. In terms of gender, identity, and sexuality, people used such a wide variety of words to define themselves. I would say that no single participant used the exact same set of words. All of our participants in this subsection were assigned female at birth, but some had undergone various changes in gender identity, some with medical intervention, some without, and of course all had been diagnosed and treated for breast or gynecologic cancer. So the first finding, I'm going to talk about 4 different major findings. The first finding is that cancer surgeries are experienced as practices of gender-affirming care. So a mastectomy is often performed as part of breast cancer treatment. Our participants were saying to us, not only is this surgery meaningful to me as part of my cancer treatment, the surgery is also meaningful to me in terms of pursuing a different or alternative form of gendered embodiment. So it stood in place not only as a cancer surgery, but also as a gender-affirming care. And this was the same case with hysterectomy. So Blake says to us, this is good news. I wanted a hysterectomy anyway. I'm just going to get this part of trans surgery done first. Works for me. To me, it was all positive. Although I was told there's a possibility of cancer here, that's not what I heard. What I heard was, I get a free hysterectomy. Our second finding is that the organization of breast and gynecologic cancers as women's cancer shapes the experiences of trans and gender nonconforming patients. So there's quite an invisibility that's then structured into how the care is provided. So what happens for folks is they're going to be going into a clinic, and that clinic is not prepared to see someone who looks like them there. So when that happens, we're hearing a lot of our participants say, I felt various different forms of service refusal. I went to get treatment, I couldn't get treatment. So John tells us a story, and he said, they told me that I had to sit in the hall, but my girlfriend could sit in the waiting room. I wish I could have said, no, I am a patient here. I also lived the first 25 years of my life as a woman. I would like to sit in the waiting room, but I didn't want to make a scene at the time. Our third finding is that there's significant overlaps in the bodies of knowledge that are informing how people are making decisions. So when people are making decisions about their gender care, they are absolutely considering their cancer risk profile in that. When people are making decisions about their cancer care, they are considering their gendered embodiment and their gender identity and expression in their considerations for cancer decision making. So Blake told us, I've totally considered taking hormones, but my partner's approach is, prove to me that taking testosterone will not give you cancer. It's very hard, the jury's out on that, so I haven't done it. And the final finding is that trans and gender non-conforming people's experiences of breast and gynecologic care are absolutely intricately linked with their experiences of intersectionality. So where they are on any sort of demographic chart of gender, race, talking about class, talking about ability, all of these different intersections are really shaping how people experience and care. And they're not able to say to us, it was because of this thing. So what's happening is when these experiences are not compartmentalized, they don't know, am I experiencing this because of my gender identity, because of my sexuality, because of my race? And they're not sure. So what they're doing is they're taking steps to mitigate and basically erase some of these complexities. So Dario said, I think it's layers of invisibility. It felt like we were these radical lesbians of color. I don't even know if that's how they read us or not, and that really wasn't where we were coming from, but that's how we felt like we were being treated. And after that, I didn't let my partner come to my appointments anymore. So in conclusion, a big, huge piece that's coming out of this is really noticing that trans and gender non-conforming people are really highly motivated to seek knowledge, get information about both cancer care and gender-affirming care. But very importantly, cisgender models of care are both medically and ethically insignificant. They are not sufficient enough to actually inform how it is that we're designing care for gender-diverse populations. So that requires a shift away from that binary organization and starting to understand sex, gender, sexuality as more of an intersectional approach. And I'll leave the final word to John. And John says, really what we're talking about here, we are talking about patient care in a clinic that doesn't need to be gendered. Thank you very much.